If I could have your attention, please. It is 2 minutes to 10. And I was told to make my announcements at 3 minutes to 10. So, we're on a tight timeline. It would be helpful, very helpful, if you would take your seats quickly. And if you happen to have empty chairs at your table, raise your hand. Sally, we have a lot of empty chairs at the table.
Anyone
If you want to
on the side
move,
doesn't come up to the table, if you haven't already.
we have a lot of wait list people sitting in the chairs, so we want them at the tables if possible.
Y'all feel like it.
Pat Sullivan has a couple of things to say.
Good morning. I just wanted to bring your attention to several things that are on your table. One is our membership form. If there are any of you that are with us here today who are not members, we would love for you to be members. It's your membership that helps bring these great programs like the ones we have, the one we have for you today. So we encourage you to do that, and there's a membership form on each table. It also has an envelope that is addressed and stamped. So all you need to do is put your check in and drop it in the mail. We also have, for anybody that's not familiar with it, examples of our really great VaCCra newsletter. And this is something that comes to you through your membership. This is one of your benefits of membership, and it is a really great publication. It's written by residents of CCRCs for residents, and that makes it very personal. The other thing that each of you have a copy of is our program for next month. And this is the end of a series that we've been doing on end-of-life decisions. And this is, I think, going to be a great workshop. I don't know, I hope that many of you had the opportunity to read in the Times-Dispatch the self-written obituary of our dear friend David Long. It was wonderful, it was inspiring, and it was 100% David. So if you did not get a chance to read that, I have a copy, and I'd love to share that with you. Ann?
And I posted it on the outside bulletin board inside,
Okay. Did everybody do that? So that you have an opportunity to read it. But it's very apt to this because this is an obituary writing workshop. And reading David's made me feel like this was something that I might really like to do. So if it's something that you feel that you might be interested in, I think this would be a great program, and there's a workbook that you take home, and there's no additional charge for the workbook. That's all.
Here's seats for you, right here. Seats over here.
We have 5 seats right over here to the right, front row. 1 seat here, and 1 at the second table there. Yes, Ann?
2 here.
You have 2 there, okay. As people come in, we're gonna place them in these empty chairs. Okay, thank you, Pat. We want to welcome you to the second in a series of 3 programs designed to help us with practical information that we need to provide to our family and our loved ones if we are unable to make our own medical decisions. But before we do that, I want somebody, Jennifer Moss, would you stand up, please? Jennifer is from Blaley's, and she will be doing our workshop next month on obituary writing, and she decided it would be helpful to her if she came and got a lay of the land. So thank you, Jennifer. Feel free to talk to everybody afterwards.
I promise next month will be a lot of fun.
Yes.
How about that? That's my
That's
only
great.
promise to you.
We are gonna hold you to that.
Yes.
Okay. We have a full morning, so I'd like to give you just a couple of instructions that will help us to move along quickly and hopefully without a hitch. The documentary, oh, wait a minute, one more thing. If you leave after the film, and some of you have doctor's appointments, you might have to. If you have to leave before our panel starts their discussion, please let Sally know. Because we will want to know how many empty chairs we have for people who are late coming in. The documentary is 54 minutes long. As the film ends and credits begin to roll, we, meaning Pat, Francis, and who else? Kay and Sally, all of us, will be bringing to your tables trays of snacks. You already have the sweetener, the sugar, the creamer, and that sort of thing on your table. Coffee is in the back, tea is in the back, water is in the back. So we would ask you to take care of your drinking needs as quickly as possible and get back to your chairs as quickly as possible, because we will be anxious to hear from our panel, who will be here in front of the stage. Okay, that takes care of instructions. Any question? Clear instructions? Poor instruction? Dolly gives me a thumbs up, so therefore I think it's okay. Okay, we're gonna now have the film.
Tonight on Frontline.
All the stuff you learned about in medical school is just a tiny little bit of what it means to be good at our jobs.
Based on his best-selling book, Being Mortal,
So many people I see, their death comes as a complete surprise.
Dr. Atul Gawande takes us inside conversations with doctors and patients about dying.
Oftentimes, what we say as physicians is not what the patient hears.
A personal journey.
My dad cried, my mom cried, I cried. He did not want to end up on a ventilator. He said, let me die.
The struggle between hope.
What do we forego by pursuing treatment after treatment after treatment, which made her sicker and sicker and sicker?
And making peace with the end.
The last couple of weeks have been surrounded by family and friends, some of the best days of my life, I must say.
Tonight on Frontline, Being Mortal.
I've been a surgeon for more than a decade now. In medicine, your first fear as a doctor is that you're supposed to be able to fix a problem, and our anxieties include wanting to seem competent, and to us, competent means I can fix this. In fact, there's often kind of implicit promise. I'm gonna be able to fix this. I'm gonna certainly give you the best shot you can have. Nobody could have given you a better shot. And then when things aren't working, part of your anxiety is, was there something I missed? Was there anything else I could have done? When I started out in my training in surgery, you discover that all the stuff you learned about in the books in medical school is really just a tiny little bit of what it means to be good at doing our jobs. It's not just about how smart you are anymore as a doctor, it's about how you have to be able to work with teams and how mistakes get made and how you handle them and how you learn. among the most uncomfortable difficulties was grappling with those cases where we couldn't solve the problem. The two big unfixables are aging and dying. You know, they're not, you can't fix those.
I'm a surgeon and I'm a writer. My writing has become the way that I can focus in and begin to understand the problems that most confuse me.
One case in point was a piece I wrote called Letting Go about a woman named Sarah Monopoly who I helped take care of, who was diagnosed with stage 4 lung cancer during the 9th month of her pregnancy at the age of 34. This was one of the most difficult circumstances. You have a young woman with a brand new baby. Of course, everybody is fighting for every chance that she's got. She was young, she was enthusiastic, she wants to tackle this. You don't want to be the downer. So you're grasping for a straw that says, well, there's something here that's going to be beneficial. Stage 4 lung cancer, we know it's not curable. But suppose she's the one that somehow gets cured. Maybe she's the one. And so therefore we should do all these things to her. Having any kind of discussion that would begin to say, look, you probably only have a few months to live. What do we do to make the best of that time without giving up on the options that you have? That was a conversation I wasn't ready to have. I don't think any of us were. Hey there.
How are you?
How are you?
Come on in.
Take me back to when she's pregnant, she's doing great. 39 weeks, your due date is coming, and
The collapsed lung would not allow for a C-section. It was too dangerous to be opening her up with all that fluid built up. So Sarah had Vivian basically pushing with one lung. It was so difficult, but she had the baby. You want to be part of that 15% that survives 1 in 5 years. You want to be that part of that group so badly. And you say to yourself, why not us? You know, it wasn't about, okay, how can we have good days to the end? We didn't focus on that enough. We're trying to stabilize the situation and try to become spend a little bit of time as a family. But it was an impossible situation, impossible summer. It was just excruciating.
When I came on the scene was when she got diagnosed with a second cancer. You know, in my mind, what I was thinking was I wouldn't offer this surgery because the lung cancer was gonna take her life. And yet I didn't feel I could say that to you all. I think we started talking about the experimental therapy that you all were hoping to get on for a trial with the lung cancer. And I remember saying something I sort of regret, which was, you know, maybe that experimental therapy will work for the thyroid cancer too. I said that, and I know it was complete.
Well, you had joined us in our sunny disposition of hoping for the best.
I knew it was not good. I mean, in other words, the reason I regret it is because I knew it was a complete lie. I just was wanting something positive to say.
I did not know that was an outright lie. You can lose your license for that.
But I think I don't think I was terribly equipped for having that conversation, and maybe you all weren't.
I don't think we were. I've thought often about what did that cost us? What did we miss out on? What did we forego by consistently pursuing treatment after treatment after treatment, which made her sicker and sicker and sicker?
The very last week of her life, she had brain radiation. She was planned for the experimental therapy the following Monday. You woke up and she wasn't doing so well on a Friday. What happened then?
So she woke up and was gasping for air, and I tried to crank the oxygen up. I said, let's max this thing out. Maybe we get a bigger oxygen machine. We're so close to getting to the next potential fix. And she said, I can't do this. I can't do it at home. I'm too scared. I'm gasping for air and I can't do this. We should have started earlier with the effort to have quality time together. The chemo had made her so weak that she couldn't hold it. It was exhausting. And that was not a good outcome for the final months. It's not where we wanted to be.
In the last 3 months of her life, almost nothing we'd done, the radiation, the chemotherapy, had likely done anything except make her worse. It may have shortened her life.
What was interesting to me was how uncomfortable I was and how unable I was to deal well with her circumstances. It felt like a revelation in that here was a case which I could unpack enough to understand. Why do we always go off the rails? It made me want to explore what other doctors were doing in these extremely difficult circumstances. What I hoped was that maybe I might learn something that I should be doing differently. I work at the Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston. They're connected together across one street. It's here that my colleagues let me observe their experiences with patients facing the end of life, the struggles and the difficult choices. One was Lakshmi Nayak. She's a specialist in cancer of the brain. And she has to have these end-of-life discussions with almost all of her patients. You picked a pretty tough field, right? So how many of your patients will you cure or help them have a better life?
It's almost always fatal. We have, each of us has an odd patient who survived for 10 years or 15 years. But that's less than 5% of all of the patients that suffer from what's the most common malignant brain tumor. So yes, I don't get to tell people, I'm gonna cure you.
One of Dr. Nayak's most challenging cases at the time was a man named Bill Brooks. He was 46 years old.
Bill has brain cancer. That basically, in his case, has led to raised pressure in his head, but he feels really well. Bill's sister had also died of a brain tumor, and that was what he was worried of the most.
Are they good?
Delicious.
They always look delicious. Everything is good for you. You eat anything. We're so lucky. We have each other. We have great families. We have great friends. We have great jobs. We live in a beautiful home. And we're lucky. And then, all of a sudden, it's like our world was turned upside down.
It's a battle. Some people say don't listen to the numbers, and I always say, well, that gives me something to shoot for. If they tell you 5 years, let's go for 6, 7, or 10.
So, Bill's story from the very beginning has been challenging because when I first saw him, I thought he had 5 to 10 years. That changed. His symptoms started getting more aggressive.
The headaches.
The headaches, the not being able to lie down. I actually called Mary. I said, we don't have much time, we probably have a few days to a month. And I told her she should take time off work.
He started having pressure in his head, and we... Tissues paper, a paper towel, tissue. So, Dr. Nayak gets very,
She takes it very
she
personal.
takes it very personally when she has to give us bad news, and she basically just told us to get ready. And so, of course you have your pity party. And then you kind of like, don't give up hope.
So after the phone call, Dr. Nyack ordered a series of spinal taps to relieve the pressure in Bill's brain, and it worked. The pressure came down, he felt better, and they had new hope. But the disease was still progressing.
You started having some pressure. Can I check a few things? Open your eyes. Eyes wide open. What I was looking into your eyes was not the way your pupils reacted, was to see what the pressure might be. And I'm worried that the disease will be growing.
I think that it's important for us, even though it would be easy to sort of skip over this today, that we should talk about if things are not going as we hope, to just talk about worst case scenarios a little bit.
And then best case scenario too.
Okay. So, well, best case, obviously, we'll just continue what we're doing if you think that's the right path.
What made you jump in to say best case as well as worst case?
I think that I scared them the first time.
You're thinking back to when you talked about it
Yeah.
before, and you were worried that you'd lose their confidence if you only talked about the bad side.
Yeah, and especially because he had been responding to treatment, that just gives them some hope, as long as you're not giving them unrealistic expectations out of treatment.
What's the third option?
There's no third option.
There has to be a third option.
But you've been on.
We do things together. We often are finishing each other's sentences. If Dr. Nyack had said, let's talk about worst case scenarios, then I would have said, and we'll talk about best case scenarios.
Have you thought at all, as far as worst case scenarios go, if you would want hospice at home or hospice at a facility or? Do it at home.
When we talked about hospice, I was reading Mary's body language that was sort of saying to me, don't go there. But given all the things that were going wrong, I felt like we had to do that.
Have you thought about anything after the MRI?
My thought, and Mary's heard me say it a lot, is I want to see the next one to kind of see if it's showing anything or not before I start to get worried or get too hopeful. Okay. Thanks. Good to see you.
Good to see you.
It was amazing to see how my colleagues had these conversations, and it was teaching me what I might do better for my own patients. It turned out it also taught me how to do better for my dad. He got some bad news back home in Ohio. I remember I took notes in my journal around that time. Do you remember when Dad first started to get pain in his neck?
He had pain in his shoulder, and he thought that either played too much tennis or just muscle. So when the result came, we were in shock.
He got an MRI, and as a surgeon, knew the results were not good. He emailed the images. I opened them up, and it's a huge mass, and it's concerning. He called me up, and as we're piecing it together over the phone, we're kind of realizing this is right in the middle of the spinal cord. So the puzzle is, how do you get this out? We're two surgeons looking at a mass. It's like two carpenters looking at a house. You're not saying, oh yeah, we can't fix this. But, at the end of that conversation, I'm thinking this could be a life-threatening problem. It was hard for us as a family to talk about this, and that's despite the three of us being doctors. In fact, talking with anyone near the end of life about their decisions is so difficult. There are actually physicians who specialize in the process. They're called palliative care physicians, people like Kathy Salvaggi, who works at the Dana-Farber. Her technique is as much about listening as it is about talking. What would be on your checklist for what I should
make sure I do when I'm doing it next time?
First of all, I think it's important that you ask what their understanding is of their disease. I think that is first and foremost, because oftentimes what we say as physicians is not what the patient hears. And if there are things that you want to do, let's think about what they are and can we get them accomplished.
You know, people have priorities besides just living longer.
Yes,
You gotta ask what those priorities are.
Yes.
You have to tune the treatment to those priorities.
exactly. And if we don't ask, and if we don't have these discussions, we don't know.
Paul and Dr. Salvaggi on campus.
Dr. Salvaggi works with doctors throughout the hospital to help with their hardest patient conversations.
So, how are you feeling?
Better than I was.
Eamon Alfiki was one of those doctors. He's an oncologist who, like me, grapples with reaching good decisions with his patients about dying. He'd been caring for a patient named Norma Babineau for 2 years. He said that during that time, he had tried to broach how dire her prognosis was, but he had not been successful.
Let me start by giving you both an overview of where we're at now, because the cancer has developed a more aggressive course to it. Right? It's a more resistant type, but it just keeps marching along. This is where the tough discussions come up. The disease, we knew, has been acting up. Right now in this state where treatment would hurt you more than help you, it's just a fact. And you would not get the benefit of it.
Is there a timeline, or?
We could be talking about 3 to 4 months. It can be longer, and it can certainly be shorter if the pace picks up.
And if miracles are gonna happen in between.
It's a question you had to ask, and I don't want you to dwell on that. If I were gonna bet on somebody doing better, I would be betting on you to do better than that timeline.
Our goal is, for whatever time is left, is to make it the best quality that we can.
But I need to take the baby over there and deliver
To where?
to Walt Disney.
Did you want this?
Yeah. Yeah, I'm gonna take her horses. We gotta find the right medicine to get me better so I can take my trips.
So the really hard part I find in these situations is, you know it'll come to this point, when do you help them understand that? What's going through your mind? What does it feel like to you?
But I wish I could do better.
It still feels like a little bit of a failure for us, doesn't it?
It's very much a failure. And it's hard.
But even though you knew from the beginning, you weren't going to be able to, you weren't curing this problem.
It's just a fight mentality that perhaps goes back to training in med school and just the way we are wired, and we're not trained for that other mode.
Yeah, that's where we have to take our cues, because I think
Palliative care doctors like Kathy Salvaggi are different. They're teaching us there might be a better way in these circumstances.
and I think it's hard to hear sometimes the timeline, but I think it's also important to have a sense, because if there are things that you want to say or do or people that you want to see, it helps you define that time a little better. I think she knew that she was getting sicker and weaker. One of the goals was to try to get her home with hospice services, but the medications and the things that we're requiring, it's just not going to happen.
Forget
It's
this
not under
anymore.
control.
We're not even knowing whether we can leave the hospital.
Exactly.
So we didn't do that before last Monday. Feels really late in the game, you know?
It does feel a little bit late in the game. We're all sort of taught that in order to make a difference in our patients' lives, we have to be doing something. We have to be operating, we have to be giving them a medication, we have to be radiating, we have to be giving chemotherapy. In some ways, I think medicine is the easy part. It's all of this other stuff that's much harder to deal with. How are you?
Good, how are you?
I wanted to talk with you about, I know the other day, Norma, we talked about where to go from here. You may need more and more IV or intravenous medications to control your symptoms, and I'm worried that we're not going to be able to do that at home. What do you think about that?
I think it's unclose.
Are you, when you say coming close, that we're coming near the end? Yeah. I worry about the same thing. And what we'll do is we'll keep you here, and we'll take care of you here. Okay? Yeah. All right. All right, we'll see you a little later, okay? Okay. Why don't I clean this out?
Kathy Solvaggi had helped Norma understand that she was dying. Still, Norma had little time to say her goodbyes. She died 10 days later.
These are really important conversations that should not be waiting the last week of someone's life. Between patients, families, doctors, other healthcare providers involved in the care of that patient.
There's no natural moment to have these conversations, except when a crisis comes. And that's too late. So I began trying to start earlier, talking with my patients, and even my dad. I remember my parents visiting. My dad and my mom and I had sat in my living room, and I had the conversation, which was, what are the fears that you have? What are the goals that you have? And he cried, and my mom cried, and I cried. He wanted to be able to be social. He did not want a situation where if you're quadriplegic, you could end up on a ventilator. He said, let me die if that should happen. I hadn't known he felt that way. This was an incredibly important moment. These priorities became our guideposts for the next few years. And they came from who he was as a person, who he'd always been. My dad came from a little farming village in the middle of India, thatched mud huts, no running water, a village of about 5,000 people. His father had 13 children. His mother died from malaria when he was about 10. That was when he decided he wanted to be a doctor. He went to medical school in India. Afterwards, he was offered a job in a hospital in New York City, training to be a surgeon. He met my mom and married her, and they moved to Athens, Ohio, to set up their medical practices and raise a family. There, he was part of the community, and that became especially important to him after the cancer. As the tumor slowly progressed, we followed his priorities, and they led us and him to choose an aggressive operation and then radiation, but eventually paralysis set in, and then our options became chemotherapy. So the oncologist lays out 8 or 9 different options, and we're swimming in all of it. Temozolomide, vincristine. Then started talking about how, you really should think about taking the chemotherapy. Who knows? You could be playing tennis by the end of the summer. I mean, that was crazy. It made me very mad because it was
completely not right. Yeah.
This guy is potentially within weeks of being paralyzed. The oncologist was being totally human and was talking to my dad the way that I have been talking to my patients for 10 years. It was holding out a hope that was not a realistic hope in order to get him to take the chemotherapy. I then pushed. We were still in the back of our mind thinking, was there any way to get 10 years out of this anymore? And she basically was saying, no. And we needed to know that. Medicine often offers a deal. We will sacrifice your time now for the sake of possible time later. But my father was realizing that time later was running out. He began really thinking hard about what he would be able to do and what he wanted to do in order to
have as good a life as he could with what time he had.
I guess the lesson is you can't always count on the doctor to lead the way. Sometimes the patient has to do it. When I first learned of Jeff Shields, he had already gone through 3 years of treatment for a rare form of lymphoma. Chemotherapy hadn't worked. He hadn't given up hope, but he was also recognizing that his odds were diminishing, even as his doctors were offering him more treatment options.
Well, my experience has been that oncologists, at least my doctors, are basically optimistic. And they're always looking for a way to push the disease into remission than they are in talking about the longer term picture of mortality. I spent time talking to Jeannie, my wife, thinking about, at least for me, I want to make a decision. I don't want to linger.
We've had conversations about all aspects of what the end of his life might look like. And most of all, he says, I want to be at the farm. And, you know, hopefully I'm in a position to make sure that happens. We have an appointment that I hope will result in them saying that the disease is lessened, but they might say, no, it's not under control. And then we're going to start having a conversation about mortality. And because I don't think there are so many more choices for Jeff in terms of treatment.
Hey, Jeff.
Hi, Rob.
How we doing? Very good. My pleasure.
Any results of biopsies?
Yes. The preliminary results do look like rare versus Graves' disease. And that's not necessarily so surprising. We expected that. I first met Mr. Shields about 2 years ago. At that point, he had bone marrow transplant. And unfortunately, about a year after the transplant, he showed signs that his disease was coming back. In addition to that, he has a complication of transplant where the donor cells are actually attacking his body. And unfortunately, it's wearing him down. It almost goes without saying, but we may have to make a new game plan a week from now.
I feel really crummy or spend the last 3 or 4 weeks of my life in the hospital is not very appealing to me.
I bet not.
And so when we get to that point, I'll rely on you to make sure we have that conversation.
Right. And it's a group discussion for all of us. All right. We'll see you guys.
It's always a hard thing, right? How do you know if they're coming towards the end versus changing the therapy again?
Well, I don't think we ever know. With Jeff, he was a very, very thoughtful fellow, and thoughtful in the sense that he had considered what might happen down the road. And he made it very clear to me that if we thought some therapy might be helpful, might prolong his life with reasonable quality of life, he was happy to go for it. He also made it very clear that if we thought that things were going to go badly, or things looked like they weren't going to work, didn't want to pursue therapy just for the sake of pursuing therapy.
It seems to me there's such a difference in these last few weeks. And we know the lymphoma is growing and sort of rampant. What I'm worried about is, could we be coming to a place where it's actually killing you? And we don't have the opportunity to really talk with the children and
where I am in what I consider in hospice, in other words, end stage. And we don't have, I am gonna live for 4 weeks, and we are thinking, oh, maybe there are 3 months.
Yeah, yeah.
I think we should ask that at our next visit.
All right.
Go into your Benadryl stupor.
Unfortunately, your bilirubin is up, but the other liver function tests are a little down. You know, I can't put a particularly good spin on that. I don't know how negative a spin to put on that, but I can't put a good spin on that.
I wanted to clarify something.
Yeah.
I said, I don't want to go back to the hospital. I want to die at home.
Yeah.
And that's really my goal.
Yeah.
And so I want you as my doctor, my good friend, to know that.
Yeah.
The hospice people will know it.
Yes.
Jeannie knows it. That's my desire.
It's impressive for a patient and a family to be so clear about their priorities, like Jeff Shields was. Accepting that life can be shorter than we want is very difficult. It's easy for all of us, patients and doctors, to fall back on looking for what more we can do, regardless of what we might be sacrificing along the way. And that's especially the case with younger patients. And that is where a doctor needs to be skilled, I think.
It's always a challenge how to say it, that this is not working and I have nothing more. I try to deliver the bad news in pieces over a period of time. I feel a lot of times they don't absorb all of the information, and that's why you have to keep repeating it. And
You saw the report books.
yeah. So the MRI, there's a little change, unfortunately. There's a small area, a new spot. It's not super large, but it's there. This is the beginning of the end. I think it's progressing to an extent that we may not be able to do anything to control it. He's one of those few people in whom, you know, if there's something that you could try, it's worth trying, rather than just waiting.
What do you think about the AbbVie? I just saw it on the news yesterday. They just got FDA approval for one of their brain tumor medications.
That drug, we actually have a trial with that drug. I'll look into it. I'll look to see what the status of that is and see if it makes sense for you to get it. It's not going to be on a clinical trial for you. If we do it, we'd have to do it as a compassionate use. And I wouldn't want to give you something if it would potentially make things worse. So I'll definitely look into that.
Bill brought up this particular drug, but it is experimental.
Are you at all worried that you would just have toxicity from the drug without benefit?
Yes and no. At this point, I knew that he wasn't gonna live for too long without anything, so whether at least he felt that he could try.
Bill was only able to get one dose of the experimental drug because he was getting sicker. The spinal taps were beginning to stop working. Push, push. The pressure in his head continued to build, and the effects were becoming undeniable. That was when he began to prepare.
I'm really declining quickly. I need a lot more help, even doing basic. I'm basic walking and things like that while they're over there. So I just don't have the strength in my left side, so if I get leaning one way, I can't catch myself.
Can I flip them?
Yeah. It took me 15 years to collect this. More valuable and more collectible things are, from back years ago.
Is it just this part of it, or not yours?
If I die tomorrow, she's not gonna know how to dispose of this properly to get the most bang for her buck.
Want me to just move all these canvas ones?
Well, those are gonna be the good ones,
These are the good ones?
campus ones, yeah.
Oh, okay.
Yeah, that one's a good one.
Oh, I like that one more than these two.
I'm just overwhelmed with everything. The mental roller coaster has been the hardest thing to deal with. It's like, okay, am I dying, am I not? Can I function, can I not? And then we try to tell you, stay positive, keep hoping, keep fighting, and I'm like, I've been doing that for 2.5 years, and I'm at the end of my ropes, as far as that goes. I can't take any more bad news. I'd rather go into the meeting and have her just pull a gun out and shoot me than have to listen to her trying to be nice while she's giving me bad news. Like I said, I'm a positive person, but I'm at the end of my ropes with it. I fought as best I can.
Accepting death comes with incredibly complex emotions. Bill's hopes for more years had turned to weeks, and the question became when to let go of treatments if they're not helping. To accept what Dr. Nyack and Sandra had been conveying about considering hospice.
I think we need to talk about what's been going on for the last few days. The fact that you didn't respond to the spinal taps. I wouldn't want to put you through any more spinal taps. There is going to be a time when we're not going to be able to deal with the pressure. With the steroids. We will be able to help with pain and in making you comfortable. I'm worried that your disease is progressing quickly. We've talked about, hospice before. And I think this is the time where we need to discuss a bit more about it.
Well, Mary and I have talked many times. My thought again is, I'm not afraid to die, but I'm afraid of all the suffering that goes beforehand. So we're trying to find out, when that is going to come to pass, just so we can say goodbye to each other.
She just promised so much information.
To hear that over and over again, but you just don't even want to think it's a reality. Sorry. Really hard. Okay. Need to be strong for you.
It was impressive just being able to be silent for a while. Were you deliberately trying to be silent? Let it happen?
Yeah. I think it's important to pause at the right time. Sometimes it's a lot of information.
Nice to see you. Good news. Hopefully the last bad news for the day.
at this point, it's just making sure it's as comfortable as he can be. And that's the most important thing. What's working against him in a way is that he's young and strong. It'll just mean that he'll linger longer. It's basically just let him just go peacefully. Unless there's another miracle. It's okay. But anyway, like I said, it just depends. All depends on him, so. Yeah, I'm gonna go check on him. I just wanted to make sure he's okay. Are you okay? I'm right here, sweetie. I just want you to be comfortable.
Bill died 2 days later.
As this home time began to unfold, I began to realize how difficult it was. Partly because our house was not organized or arranged to comfortably do this. Suddenly you have a hospital bed in the middle of your living room.
Then I need you to help me bring my feet up.
Don't know that.
Here, Malcolm, we're gonna help Papa take his slippers off. Can you do that? You want it to be as comfortable and happy a place for him as it can be. At the same time, it's sort of the elephant in the room. Just leave that.
Have I talked to you at all about my thoughts on dying? Is it too hard? Okay. Let me just tell you this, I'm not afraid of dying. I've had a long and wonderful life. And one of the nice things about being at the farm is that you realize everything dies. There's a cycle of life. The cows die, the trees die, the grass dies, the fish die, and people die.
Aren't you sad that you're going to be missing out on all the things?
Well, I will be. And, I had hoped to have another 10 or 15 years. But you don't always do what you want. I love you.
I love you too.
See you in a few minutes.
In those last weeks, as his space narrowed and narrowed to that bed, it grew in terms of the people he was drawing in. I hate to cry, I'm sorry. But that's another one of those paradoxes, as your world comes closer and smaller, it becomes bigger and bigger. And he was seeing that.
The last couple of weeks have been surrounded by family and friends, and it's been terrific. Some of the best days of my life, I must say. But then there's a downward trend that's more rapid than I had expected. I felt great during that time, and my body was in rapid decline. Since then, my mind has been in rapid decline. I get confused.
So, but I'm still a happy guy.
Jeff Shields' words about his last weeks being his happiest seemed especially profound to me because they were among his last words. He died just hours afterwards. In medicine, when we're up against unfixable problems, we're often unready to accept that they are unfixable. But I learned that it matters to people how their stories come to a close. The questions that we ask one another, just as human beings, are important. What are your fears and worries for the future? What are your priorities if time becomes short? What are you willing to sacrifice and what are you not willing to sacrifice? My father answered these questions. He entered hospice 4 months, as it would turn out, before he died. And he was a person mostly during that time. He was not a patient.
You know, my dad Skyped with everybody back to his village in India. He had me and my sister come there and be with him. And he remained in control of the priorities that were most important to him.
I remember sitting in a chair, reading the newspaper, light coming in the window. My mother and my sister were having a conversation. And then we realized he wasn't breathing. We waited to see if there would just be one more breath. And there wasn't.
My dad made his wishes for what his life would be like to the very end very clear to us, including for what should happen even after the very end. He wanted to be cremated in the traditional Indian way, and he wanted his ashes spread on the Ganges River. We took his ashes, my sister and my mother and I, to the ancient city of Varanasi, one of the oldest cities in the world. With a Swami and a boatman taking us out in a dinghy, and it was an amazing thing.
Millions, literally millions of families have brought the ashes of somebody in their family who's died to the Ganges. That connection to people going back that many years makes you feel like you're connected to that many years going forward as well. You're just this speck in time.
But I felt he had brought us there and connected himself to all that was important to him. How is dying ever at all acceptable? How is it ever anything except this awful, terrible thing? And the only way it is because we as human beings live for something bigger than ourselves.
Possible by contributions to your PBS station from viewers like you. Thank you. And by the Corporation for Public Broadcasting. Major support for Frontline is provided by John
testing. Any of you around the room, please come to the table. There are plenty of places you can see better up here, and we'll have snacks out in a minute.
He's gonna adjust it. Okay.
Testing.
Okay.
I'm all right.
Hello? Can we begin to make our way back to our seats, please? Sally wanted me to mention we have this book in the library, and if anybody would like to borrow it, see me, I'll let you have it. Just return it to the library. No sign out, just return it. I wanted to take a minute to introduce the panel. I think you all know them all very well. Ann Hopper, we know Ann. Dr. Cook, Melissa Ellison, and Catherine Henderson, who never really left Cedarfield. Yeah, that's right. Catherine, are all your colleagues here? Okay. I want to introduce Brittany Harding, who is palliative care nurse practitioner. Wait a minute, we can't see you, Brittany. Melissa Sissick, RN, is she here? These are all affinity care colleagues of Catherine's. David Hasmer, chaplain. Here he is. Hi, David. Robin Rio. Robin, music therapist. Rebecca Harvey, are you here? Well, welcome. We're glad you all were available to come with us today to see the documentary, and these folks are available if you have concerns or questions after our panel. Okay? Okay, who's going to be number one? Ann, all right. If you all, they have lavaliers. If you can't hear, we also have a handheld mic. We will have questions. Do you want to do the questions as you speak, or do you want to wait until the end to do the questions? Whatever.
As we speak.
Okay.
Okay. Yeah, make it a little more informal. Good morning, I'm Ann Hopper. I'm going to get started with what is a DNR. You hear about that DNR. So it is an actual medical order. There's a durable do not resuscitate form. It's a medical order that you would fill out, you would sign, and your doctor would sign it along with you. And basically this order talks about what happens if your heart stops beating or you stop breathing. If you are do not resuscitate, that's it. Nothing more is done. But now keep in mind, it does not mean that you do not get medical treatment if you have a respiratory infection. We're strictly talking about no chest compressions, no assisted ventilation, so not being intubated. So it applies to your heart when it stops beating or you stop breathing. Can a DNR be revoked? Can you decide one day, you know what, I've thought about this and I'm not ready to be a do not resuscitate. I do want everything done, as much as can be done, and then basically your power of attorney would step in with the doctor, but you'd be in the hospital at that point. Just to let you know, you can make a decision, you could be a DNR one day, and the next day you can say, I don't think I want to do that. Most of the time, the ER doctors get involved, and so that's when it could be really emotional because there's an emergency involved, and that's where Melissa might talk a little bit more about planning. How about I hear my advance directive mentions that I have no life-saving measures that I want. Does this apply then? Because maybe that means I'm a do not resuscitate. You could have that language in your advanced medical directive, but most of them are about 10 to 15 pages long, and no one is going to take the time to flip through to see what your wishes are. So in the state of Virginia, you need to have this durable do not resuscitate form completed, and that's what we send out when you go to the hospital. Who signs this do not resuscitate form? You would sign it. If you were incapacitated, your responsible party, your power of attorney would sign, and a doctor signs. How do I become a DNR? You start with your doctor or the social worker. You have to get that paperwork initiated, and then the doctor needs to sign the order. And then whether you're with a Cedarfield doctor or a community doctor, once that do not resuscitate form is signed by you and your doctor, Bonnie puts it, there's a code status on the vial of life, and Bonnie will put DNR. And then that form goes back to you, and we ask you to put it on the back of your door in your bedroom. And then that's where people would look. It's on the vial of life, and then if you go to the hospital, it goes out with you. And we have a copy too in the clinic. Some people have asked me, what about, do I need to have this DNR form with me? And yes, you do, but not everyone is walking around with a paper copy with them. There are actual bracelets that you can get, and there are 2 vendors that I know of, and I put the form in the back of the fellowship hall that you can get on the way out to look at. They're the approved vendors that would have your information on it so that it's a bracelet. So that could be in lieu of the paper. I think they still prefer a paper copy, but not everyone always has it with them, so they would medical people would honor the bracelet. And then my most urgent message for you all today would be talking to your family before a crisis happens. What are your wishes? Or just thinking about it. I always say, what's your plan? And everyone's plan when they first come to Cedarfield is move through the continuum, and as life goes on, they're like, I'm coming out feet first. So my whole thing is, what's your plan? And next, yes?
And you just mentioned you put the vial of life or the thing on the back of your door in your bedroom. When I lived in a cottage, we had it in the refrigerator.
Oh, okay. I'm sorry. So the vial of life is that paper that Bonnie updates a lot for you, and it goes in your container, in your refrigerator, and that goes out. Because it's that small little container, we can't fit everything, but most people have that DNR on the back of their door. And so we would be grabbing the vial of life and the DNR, and you would go out. Sorry. Thanks for the clarification. Yes.
I think with the bracelets and so forth now, that they're now also using QR codes on those so that your information can be entered, and the EMTs can scan that and get your information. With the information technology,
That's great. Can you just repeat that in the microphone so people can hear? That's wonderful.
It's on.
It's my understanding that the bracelets and so forth now can come with QR codes that can download your medical information, your DNR, etc. And so the EMTs and other people can just scan that and get all your information. I don't have the renders and so forth, but I've read about it.
When you are hospitalized, who can access information and make decisions with you when you are hospitalized?
It would be people on your, like they call it like the HIPAA form, but the health, insurance, privacy acts, just people that you've authorized to have information about you.
Healthcare power of attorney.
Yeah.
Healthcare power of attorney. Somebody else has a question back here. Who is that?
speaking mostly about independent residents. However, if your loved one is in healthcare, does the DNR form need to be in the room, or everything just goes with the person when they have to go to the hospital?
Yeah, my understanding is anytime you change from one facility to another, or one level of care to another, it should be reassessed and confirmed. Because as Ann was saying, the DNR is something that one can change. Like a good example would be, say you've decided you want to be DNR, but then you need a pacemaker. The cardiologist who's doing the pacemaker might say, hey, look, if your heart stops while we're planning this pacemaker, we have everything here needed to bring you right back. So it's something that can change. But yeah, to your question, Denise, yeah, we should be reevaluating that, and confirming that, but it's, the vial of life transfers, yeah.
But it's not on the back of the door in healthcare. And that's the thing. I'm more concerned with 400 residents over here. And if something happens, that's the first thing I'm yelling. Does anyone know? Like, I had an assisted living resident with a caregiver over here one summer, and she went out. Now, my first question, is she a DNR? And the caregiver didn't know. And so there's a Good Samaritan law that, we're gonna do everything we can until we know that someone's not a DNR. So first thing we're gonna do is CPR. But in healthcare, it's not on their doors, because when they're sending them out, they know what everyone is on those levels of care, and then they act accordingly. And if they go out to the hospital, they send the transfer records with the DNR. So it's more cut and dried, I feel like, on the license side.
That's a good point. On the license side, it's all in the computer. There's actually, when nurses are checking people in, they have to put, full code or DNR. And so when they print off those records, it's on the forms that go with the resident. So it's part of the chart. Yeah, I think just some reflections I have, like a lot of things in life, the more experience you have, the more prepared you feel, the more thinking and preparation you do, the better off things, go for you. I thought this documentary was really helpful, just, sharing different people's experiences. I was just observing, a couple things. One thing is, doctors are human. We don't always do things perfectly. We're still learning. And then we don't have a crystal ball and can't predict the future, so we do the best we can. So I think, their humility there, I appreciated that. And then, for example, the 46-year-old guy that was younger with the brain tumor, he didn't have the luxury of a lot of life experience, and this came on him pretty fast. And so those kind of circumstances make things more challenging to come to terms with what's going on and, make these difficult decisions. The older gentleman who had, lymphoma, he probably knew he was heading in this direction for a while. Plus he had more life experience, and so he was able to, I think, be at better peace with what was going on. So I'll just say we all come to the table with, different experiences. I think some of the more helpful things that I would encourage you all to do is just to, think about what's important. In the movie, when they mention, priorities, I think that's key, and that differs from one person to another. In the book Being Mortal, he highlights a couple different examples. His father was one of them. His father was real clear. I don't want to be a paraplegic. I still want to be a person. I want to be able to interact and be somewhat independent. But there was another person in the hospital who said, if I can eat ice cream and watch football, that's all I need. So, people have different priorities, and you can't just, assume that everyone feels the same as you, because we're all individuals. So that's kind of, your friend might have one idea about how they want the end of their life to be, or you might think you would do something differently, but it's really for that individual to determine. And then, something they didn't touch on, but when, there's some dementia involved and stuff, if the cognition's affected and the individual's not able to decide for themselves, then it's really up to the family to, best they can, from how they knew the person and things that the patient said during their lives, to determine what they would want, just to kind of infer that and, speak on their behalf. So yeah, I just encourage you all to think about it, read the book, and then, talk to family members about it too, just so, your children or spouses, they have a better idea of like what's important to you, what would be a quality of life that you'd be okay with, what are your thoughts about, hospice. Some people, they want to keep trying things until there's nothing more to do. And then other people, they have the mindset, and sometimes I like people to think about it too. In modern medicine, we can keep going for as long as you want, and just because we can doesn't mean we should. So, that's where, it's important to pause as a patient to determine, do I want to keep proceeding here? Especially with some treatments, chemotherapy is a good example. There's a good chance that your quality of life might be worse for the next couple of months with the chemotherapy, just to extend it a couple more months, but is that quality time for you? Some people would say, I'd like 2 great months rather than, a year of just side effects and, poor quality. So, but yeah, every disease is different, every individual is different, so it's just good to think about. Y'all, y'all are planners and y'all are here because you've kind of thought about the future, so y'all are likely better equipped than others. But yeah, we only die once, so that's kind of the challenging piece, You don't get to have a bunch of do-overs and learn, so it's hard.
I can't remember if it was this particular book or another one where the doctors were not compliant. In other words, the doctor kept pushing the patient for more and more treatment. And because, as the doctors always felt, I want to do everything I can. And that became a conflict with the patient and the family. Because maybe the patient wants something and my daughter doesn't, and then the doctor takes her side instead of my side. I don't know. I'm just pointing that out, that's a possibility.
Yeah, that actually does come up a fair bit. It's helpful to remind, the children that, this isn't what you would want if you were in your dad's shoes, but it's what would your dad want, if he could speak for himself. Or sometimes I'll say, if your dad could see himself now at age 50, what would he want for his current self now, based on what we know about him. And you're right, it might differ within the family, but the key thing is to honor the individual, the patient's wishes. Y'all might have other things to add.
When I was working in a hospital, there was a gentleman whose heart was essentially mush, and the doctors kept trying to get his son to make him a DNR, and he kept refusing. And then one day, his father coded. He was in the room. He had told them he wanted everything done. And then after the code was over with, and of course, his father was gone, he said, if I had known what a code entailed, I would never have had him go through that. And I don't think a lot of people do understand what happens during a code, especially in a hospital. And we all felt like, well, it's a little late, but at least he came to that conclusion eventually.
Yeah, the DNR discussion, it's a challenging one, and it's a really, in some ways it's a difficult decision. I think nobody wants to, quote, give up or not try. A lot of times I'll have the question to ask, well, because it can change a little bit, but I try to remind folks that, if you code and your heart stops, something significant caused that, whether it's a heart attack, or if your breathing stopped, a stroke, or a embolism to your lungs, something significant caused that. After the resuscitation, you're going to be left with that significant problem, plus, maybe some other organs are damaged from the lack of blood flow and oxygen. So, after a code, best case scenario is you're just the same as you were before, but generally, whatever caused the code's still with you, it needs to be dealt with, and then the results of, the damage from lack of oxygen's there. So, if quality of life is key, and that's the most important thing, then, some people would consider DNR in that situation. I think, the person's health conditions, are important to consider. And the setting as well. I think, somebody might be, for example, full code when they're on the table getting the pacemaker done, but then, because that's the best place to have your heart stop, because they can get it right back, and then you're not going to have any negative consequences. But, there's great nurses here at Cedarfield, but there will likely be a delay, in the resuscitation efforts. And so, you think about that, but it's a really individual decision. But yeah, there's a lot to consider, and, I think people who've witnessed, what's going on with, seeing a code in action is, it's not pretty. So yeah, the more you know about anything, the better the more informed you are in making decisions.
I'm going to take a risk and do something for you. I'm going to be the elephant in the room. And for our age group, unless you're standing by the bedside, the chances of recovering with any facility is way down low, around 5 to 7%. So it's a good idea to consider the DNRs.
Had this conversation a little bit. I was out one day at a restaurant here with my son and daughter-in-law and family, and the person in the next room coded. My son happens to be the head of hospital medicine at VCU Health and Hospitals. He was right there. He administered CPR, the EMTs came, that man went to VCU, and several weeks later, my son and that man were interviewed on TV, one of the news stations, because he had recovered fully. So there is a chance of full recovery if you happen to have the right person nearby.
It's going to be close.
The chances are probably 2 to 3%.
I'm very naive. What happens on the code?
chest compressions to kind of get the blood moving through the body, to simulate the heart beating. Ventilation efforts, although that's like not as prominent as it used to be, because we found that the circulation is the most important piece. And then, if there's a defibrillator available, that's placed on there to shock someone out of a rhythm. If you're in the hospital and there's medications available, then there's, medications like epinephrine or adrenaline, that can be administered too to, help revive the person. And then as well, when the ENTs come, or when you're in the hospital, the endotracheal tube to make the breathing more efficient, that's involved too. So those are the main aspects.
If I could just add, being a nurse and having been involved in it, when I see it on TV and someone does code, the first thing they're doing the light compressions and the person's in the bed. Anyone that's medical knows we're pulling you on the floor and we are jumping on that heart because we gotta get it to move. And so the cracking that we hear from ribs, because that is the reality. We are pushing on that heart.
Melissa, go ahead.
Hi, I'm Melissa Ellison. I'm the independent living social worker. As I've met so many of you, I hear about your amazing travel stories going around the world to fantastic places. If I had to hazard a guess, I would bet that not one of you walked into the airport without a ticket and an itinerary and a destination. That is exactly how I feel about planning for your end of life, is to have a plan. Whether that's your advanced directives, having your medical power of attorney, your financial power of attorney, having an updated HIPAA form, all of these come into play. And I like to say that they are a gift to your loved ones, because when you're in crisis, your family is able to focus on being there with you instead of worrying, what would mom have wanted? Is this what dad would have wanted me to have to do? Is this what my husband would have wanted? By already having those discussions, those hard discussions, but those frank and important discussions, and having the legal documents in place, it allows time for your loved ones just to be that, your loved ones, because the decisions have already been made by you when you had the opportunity to have a voice. When you first moved into Cedarfield, we asked that you bring your advanced directives, and I think the majority of our residents come in with them. They are something that you need to be reviewing every few years, because just like going from a full code to a DNR, our opinions sometimes change about what we would want or who we would want to share information with. So it's always important to review those, review them with your families, that way they know your wishes. I've recently worked on updating our HIPAA document here at Cedarfield. That is the document that with your signature gives us permission to speak to the persons you've identified about your protected health information. The overwhelming response that I have received is, oh, I already filled that out. And I'll say, oh, you filled it out when you moved in? Well, yes, Melissa. When was that? 10 years ago. As I look through our records, I'm seeing blank HIPAA forms, or forms that the only party listed maybe is a spouse or a sibling who is deceased. That means if your daughter calls me and says, can you tell me how your mom is doing? Not only can I not tell her how you're doing, I can't confirm or deny that you live at Cedarfield. So I have a stack of those documents with me today. I would love for you to take the time to update those, and to also consider, if you do not have those advanced directives, we can schedule a time to get together. There are a couple different options of forms that you can complete, and discuss those with your families. What I wouldn't want is you to say, let's meet, give me the form, I want to fill it out and sign it today. No, these are serious decisions, and I want you to make sure that you are taking the time to talk with family and to really consider your options before we put that to pen and paper.
Melissa, what if you don't have family?
Right. So many of our residents don't have family or they don't have family locally. That's a great time to come make an appointment with me, so that way we can help to identify someone who can be that RP, that person who can make those decisions.
Any questions of Melissa? What does Cedarfield do when an individual who might be critically ill here at Cedarfield in healthcare and has no family? What does Cedarfield offer? How are they taken care of?
Well, that's where we want to make sure that we have those documents in place ahead of time. That's why we want to plan for that.
So you're saying somebody has to be on that document? Okay. Could be a friend?
Could be a friend, yeah. Could be a neighbor. Some folks who don't have family, they use an attorney. I've seen bankers, former neighbors. It doesn't have to be what we consider biological family. It's that person who you trust to carry out the decisions that you want.
So I guess I'd like to add that when they get to the license side too, there's social workers in every level of care. So there are, like Dr. Cook was saying, paperwork transfers over, but someone is still doing an admission paperwork. So they are going over who is your responsible party. Are you? Because you might be making all your medical decisions and everything's been made and these are my plans. Or if something happens, yes, I want you to contact my daughter. Or someone's going up there and they already have memory problems and so they're not making those decisions. So that is gone over with to avoid that emergent problem when all of a sudden something comes up.
On the form that we fill out, 2 questions. Does the person on there have to be local? And second, can you have multiple people?
For both, yes. For your advanced directives, you can appoint, the technical term is an agent. You can have an agent and an alternate. And then the HIPAA form, you can list 1, you can list 21.
Do they have to be local?
They do not have to be local. Nope, they can be anywhere in the country. I also have HIPAA forms that have international names listed.
So I hope I described this correctly. See, a person is in assisted living. They don't have family. They have serious memory issues. They only have friends who have interest and see that things need to be done. Can that person, can these friends find out who the power of attorney is?
That's a really good question. I'm a by-the-book person, so if you were to ask me, I would not be able to provide you with that information.
What do you do about that?
So, as I'm the independent living social worker, there is a social worker on assisted living and a social worker in healthcare, so that's where I would defer to them, that you would have a conversation with the team on that level of care.
This series started out because we had people here, residents, who came to us and said, we're afraid of the dying process because we have no family, we have no advocate. And we stress that you're not losing control if you plan ahead. You do everything humanly possible to get your own life in order, then your death will be in order. And Cedarfield will do everything to assist from that point on. But it's a process that we can help control.
Catherine?
Alrighty. Hi everyone, my name is Catherine Henderson and I am the bereavement coordinator with Affinity Care of Virginia, a hospice that is independent and separate completely from Affinity Funeral Home, which many of you all may know of. Thank you, Charlotte and Sally and the entire committee, Kay and Bob and all the folks that I've had such a privilege and joy to work with since back in September. It is always wonderful to be allowed back here, so thank you. And thank you all for attending the program in January, well, even September, but the program in January and today. These are not easy things to consider, and they're hard conversations to have. They're not simple. I think Dr. Gawande did such a beautiful job of pointing out that this all comes with complex emotions. There is no simple, direct route through it. So I just say, give yourselves a round of applause for being willing to really have this conversation and contemplate this. And along with that, I just want a big shout out to the team here at Cedarfield. I know y'all know them, but the entire social work team, the medical staff, the chaplains, and all the team members, they are all here for you all to support you through this planning process. And so those conversations, there's a lot of people who are eager to have them with you. And you all know this, but I'm just going to reflect it back to you anyway. You all have each other. This morning has just reminded me with Dr. Branson and June, y'all have an awful lot of medical professionals amongst you as well, a lot of social workers, and a lot of attorneys, a lot of resource people, plus y'all have a lot of friends. Y'all are just one of the most amazing communities I've ever had the privilege to serve in, and I've been part of lots of them over the years. And just the way that you all are open with one another, you look out for one another, and you have genuine conversations, heart-to-heart conversations. That is really amazing. And so I just want to encourage y'all to continue doing those sorts of things. As this process goes on, and maybe you're looking at your advanced directives, working with Melissa and having some of those deep conversations and just realizing maybe there are things that I really want to refine here. There are lots of resources out there for y'all. I don't know if a lot of y'all were at the program in January and September, but there are sheets on your tables with a list of some of the resources that you can look at for planning. Also, our team, the Affinity Care team, we are not just here to serve the folks who are on service with our hospice. We're here to support each and every one of you. So, like Charlotte was saying, after we finish today, if y'all would like to stay and talk with them, that's what they are here for, to answer your questions. One of the questions Charlotte had asked me to address, I'm actually going to defer until the time after we finish, which is really what is the difference between palliative care and hospice care. One of our palliative care nurse practitioners is here. She can help with some of that. It is a little confusing. They are separate, but they are similar in some ways. The federal hospice program is an actual program and has a lot of rules and regulations that we abide by. There's just a lot to go into with that. So if any of y'all are interested in talking to Brittany, she's here. She's super knowledgeable and helpful, and she actually has brochures of what is palliative care. So if any of y'all want one, she can give that to you as well. The other question that Charlotte had asked me is, in hospice, how do we help folks deal with fear and anxiety? And we saw just such an extraordinary vision of that in the documentary, right? I've also got to have a shout out to the folks who allowed their lives to be documented for this frontline program. Took a tremendous amount of courage to allow someone in those moments that were just the most intense personal moments of their lifetimes. And I feel like, I don't know how you all felt, I felt like just a keen sense of what they were going through. It made it very real. And it is part of why, as hospice professionals, we often feel such a deep sense of privilege that we are allowed into people's lives. And so that is a big way that we help folks deal with the fear and anxiety. It is as a team. We are an interdisciplinary team. It is the medical professionals and their expertise in pain management especially. I think you heard the one gentleman say it wasn't dying so much that concerned him, it was he didn't want to be suffering. And so that is an important part of what our team does, is addressing the actual medical needs so that folks are comfortable. And a big piece of it also is our chaplains, our spiritual support team, our music therapy team. They are therapists and very skilled in working with music as a form of therapy. Our social workers do both logistical kinds of things like what Melissa was just talking about, but also emotional support and family support with resources is a huge thing for end-of-life care. Like you saw, I think it was Jeff going home to the farm. And so I can tell you there were a whole fleet of people making that happen. And the woman who wanted to go home, Miss Babineau, I think, her doctor said, you know, it's really not gonna work very well. You're gonna need to stay here. Those kinds of discussions, the guidance, the involving everybody in the decision-making that is appropriate, those are the kinds of things that our care team works on. There's also a volunteer coordinator who helps with volunteers being part of the care for a family member, and they're a very important part of the program. And our medical director, our nurse practitioners, it is a whole fleet of people, our home health aides. Some of you all may have met a lot of these folks that I'm describing, and then bereavement support. All of those are required parts of the federal hospice program. If we want to have a program, then we have to have folks to fill those roles. We work together as a team. We meet every week to make sure that folks are getting the best possible care. And I've seen it many, many, many times over the years as a chaplain visiting in folks' homes, that folks would come out of the hospital in a state of absolute chaos, and on hospice, it's the whole bottom had dropped out of their lives, and they didn't think that they would live much longer. I have seen countless times when they stabilized and even were eventually discharged from hospice. And I've always thought that a big part of the reason was because the hospice team providing that safety net, that sense that there would be a nurse on the phone at 3 a.m. if they needed it. It brings the anxiety level just way down, and folks start to calm down. Everybody does better, and folks in general physically can do better as well. So that's a big question, Charlotte, and I'm gonna stop with that there. The one thing that I would like to leave with you is very similar to what you all were just saying. And you saw Dr. Gawande, you know, I can't say it any better than he said it. There are things in everyone's lives that cannot be fixed. They cannot be changed, no matter how much we might wish that we could change them or fix them. The one thing that we can do is step back to the extent that we are able and gain some perspective on our whole life experience, our entire life journey, our relationships, the things that we've done that we were pleased with and the things that we were not so pleased with. And coming to terms with all of those things is a part of the journey that for us working in hospice, we think about this all the time, is a sacred journey. And we saw that again with Jeff. You know, just him being able to talk to his grandson and say, well, yeah, you know, I do want to be here with you, I sure do, but everything here is going to die eventually, and I accept that. So that process of coming to terms with our mortality and everything that goes along with that, having those times to say goodbye or say whatever it is you want to say. I just encourage you all to take advantage of the opportunities here at Cedarfield to do that kind of work. We talked about this some in January, the wonderful legacy projects and programs that you all have going on here. That's a great way to do that, for example. And I'm gonna end the way I started by just saying what a phenomenal team you all have here at Cedarfield, and knowing that they are here to help with all of those conversations and coming to that sense of perspective on your whole life, including the things that you can't fix.
I have one question. What is the exact restriction or allowance for the use of morphine in the last days of your life? You hear regulations that say, well, you can't give us so much because people might get addicted. So what exactly is the truth?
I'm going to defer to Dr. Cook on that one.
Yeah, I'm not I think the most, what we'd like to avoid the most is to not provide comfort. So I'm not aware, and like, if somebody has a terminal diagnosis and they're actively dying, I'm not aware of any limitations for the morphine. I will say, you know, opiates and morphine, you know, come with a lot of baggage. But yeah, end-of-life care is a great use for it. Something I wasn't aware of until, you know, onwards in my training was that, you know, morphine, we think about it for pain, but it's actually, you know, it calms people, and then it really helps with like the sensation that you're having trouble breathing. So that's one of the more important purposes of morphine at the end of life, is just helping with, you know, any sensation that you're having trouble breathing, if, you know, that's what they're going through. Yeah, and we're not, in that short period of time, because you're not taking it yourself, you know, someone's providing it to you, it's just different. It's not, yeah, you don't worry about the addiction and, you know, people, you know, deliberately overdosing because they're not giving it to themselves.
Any more questions? We at VaCCra are concerned with helping to get a program kicked back into existence where some of us as citizens, residents, can go sit with the dying. And I think that's something administratively we can work out. But exactly when someone is dying, how, it's their journey. Is it just alone? How much does it matter that the family's in the room or anyone's in the room?
Would you like for me to tackle that? Okay. So that's a great question, Sally. It's something that I've been privileged to be present for many times. I don't think there is a cut and dried answer to it. We had talked about the 5 wishes and folks being able to specify if they wanted someone with them or if they wanted to be by themselves. Some folks really do, I think, want to be by themselves, and some folks want everybody around them and not to leave their side. My personal belief is that there is way more going on than what we can actually see by sitting next to someone. Some of it is an intuitive sense that what is going on beneath the surface is much greater than what we're seeing outwardly. So I gave an example of this. I think one of the other talks, I'm gonna mention it really quickly. I was at a bedside at someone who was in an ICU, and for whatever reason, was still hooked up to a monitor. Normally that wouldn't have happened. The person typically would have been disconnected from the heart monitor. But the family had invited me in, and they were reminiscing. They were telling stories. It was a big, jovial family. They were having a great time telling stories about their life together. And the patient's daughter said, "Look at the monitor." And we all turned and looked, and her heart rate was just going up and up and up. And so we all looked at each other and we said, wow, she can absolutely hear everything that folks are saying. And I had believed that for years of being at folks' bedsides, but here I had actual tangible proof that someone who outwardly showed no signs of being conscious whatsoever was taking in everything, all these great stories, the laughter, and just the love, just the pure love in the room. So I was there for a while, and eventually the family, they were wanting to get some lunch, and so asked me if I would say a prayer. And so I gathered everyone together, invited them to offer a blessing to her, said some prayers with them, and the heart monitor, can you guess? It just went right down. Just so completely calm once again. So I trust that there is something going on that happens without us really knowing, that when someone is present, and in hospice we call it keeping vigil, to be present to someone, I trust that there is something real that happens when someone is offering love and blessings to a person as they are dying. I also think, and this is important, I think folks also need some solitude, because the thing that we often don't think about is that the person who is dying is saying goodbye just as we are saying goodbye to that person. And that takes time. It's not easy. Some folks can do that more easily, but for some folks it really can take them days and days and days. And so being present with them however they are, in whatever it seems like is going on, which is, don't get me wrong, talk about an emotional roller coaster and something that can be excruciating. There's nothing that's harder than sitting with a loved one who is dying and not knowing what are they thinking, what is going on. So I think it's both. I think there are folks who genuinely love having the people there, feeling that tangible sense of love. And I think folks also need solitude to work things out. And I know you all probably know stories of this and have probably experienced it yourself, of everyone leaving the room to just take a break and the person passes. So there are all these mysterious things, which for me, fortunately, I'm good with that. But it's not easy for everybody. A lot of times it is hard not knowing.
Thank you, Pam. We appreciate your being here, taking time from your work to be here with us and answering our questions. And thank you, residents, for attending. We've had a tremendous response to all of our programs, and I hope we will continue to. We're going to be continuing programs that are of interest to you, that you want. And I think some members of the team and members of Catherine's team will be here for several minutes if you would like to speak to any of them, if you would like to continue some thoughts, your conversation about the film, if anything concerned you or bothered you, if you'd like to discuss it with a professional, we have the professionals here for you.
Charlotte, could I just add one thing? I just wanted to mention we're back Rebecca is here now too.
Rebecca is here.
Yes.
Before you leave, before you run out the door, people, just listen 1 second. You see the snacks on your table? Take them home, please. And thank you all for coming.